Uh, I think that similar to coronary work, the calcified PAD lesion must be the number one obstacle for all the interventionists. I'm the cardiologist and producing many research activities and many directors in our Korean academic society, especially I'm current vascular intervention society president and leading many vascular intervention among the cardiac surgeon and interventional radiology and our interventional cardiology and the vascular surgery. And all the coronary intervention, especially complex intervention, I'm enjoying. So we have 3 Korea University hospitals. I'm working at the Korea University Kuro Hospital. This is our usual, most of my patients are critical ischemia patient, wounded patients, and we are developing this wound protector doing many patients we are calcified and diabetic foot, and most of them have the significant wounded patients. And those patients have more than 70% coronary disease patients. So these BTK patients always need, I like this patient because the simultaneous coronary work I'm doing together and the same monitor for the BTK and the SFA process. So total 6 monitors we are doing. And this is the usual BTK direction. We are doing the BTK intervention like this. Number one problem is the wire passage failure in calcified region. Today, I'd like to, due to time limitation, to focus on this balloon passage or the dilation failure. So first of all, tomorrow I will do the only one focused issue for the external piercing technique tomorrow, but simple sample. This is you can see this is a stumpless lesion, far distal focal stump here. Where's the ATA TP trunk? Anyway, the subintimal angioplasty we have done, and some distal tibial vessel. You can see this is a coronary non-compact balloon, not expanding well, non-dilatable lesion here. About 10 coronary non-compact balloon were ruptured like this. So this kind of after peripheral and coronary balloon angioplasty, this is a single runoff. This is a non-dilated lesion. But focal non-dilated is good indication for piercing technique, superficial area. So this is to show the educational purpose. At the time, the BTK stenting was available in Korea, export from Medtronic. 340. This is undilated. You can see fluoroscopic unexpanded stent. So this is good demonstration purpose. So circumferential piercing, you can see multiple retrograde puncture fashion piercing. With the time, you can see the stent is expanding. This is what the piercing working for the focal non-expanded area. Now the stent stroke was expanded, and easily the non-compact balloon expanded. You can see the injured area. This is the usual fashion after piercing. However, the prolonged balloon inflation, the plaque sealing this prolonged inflation effectively seen in the piercing area. So good distal runoff can be achieved. No residual stenosis. After 3 months, you can see good distal patency is achieved. So second one is excellent balloon performance. You can see that non-compliant, pure non-compliant balloon is also working nicely in some calcified area. And this non-compliant balloon and semi-compliant balloon does not work in calcified region. The third one is multiple, similar to coronary CTO, multiple parallel CTO wiring, you can make a space and then balloon can pass. Sometimes you can use the rotablator, and this good performance CTO wiring you can try. And rotablator can work in some particular case in the little longer calcified region. And Brukenbro needle in SFA CTO and BTK CTO, some tough method. However, this longitudinal bugination by the broken needle can work in make a space, and along with the wire, dancing with the broken needle. However, digging aggressively, then balloon can go, then it can make a space, then do the final angioplasty result. Sometimes tonus PV, which can dilate like a manual rotablation using the coronary CTO device, this can also make a space. Sometimes CTO devices, diamond drill with the true pass or the front runner, and sometimes with biant CTO crossing catheter. This is one of the crossing catheter. Let's suppose that this is a total occluded manual rotablation, the totally occluded segment, just drilling. Then at certain point, this can crossing, then a 14 wire can easily go down into true lumen and dilation. So this kind of a little bit modifying the focal calcium, and special plaque modification or calcium modification device can help, like this Jetstream. Jetstream you can use in the both SFA and the BTK use. We have 4 different Jetstream catheters, and the smaller one, 2.130, you can use in the BTK. For example, Jetstream use. This is before the Jetstreaming. You can see the post-tibial diffuse disease and the multifocal calcified region up to the below ankle. And this after crossing the 14 wire, this is a Jetstreaming, rotablating fashion. This is a less stronger than the rotablation. However, less calcified area, but longer lesion, you can do the debulking by the Jetstream and the additional balloon angioplasty. Then this can work nicely. This can go down just above the ankle level, 14 wiring, then further Jetstreaming like this, and the prolonged balloon inflation up to below ankle. Then you can see the before and after the Jetstream. This can provide a significant plaque debulking. Then the balloon angioplasty results can be quite good in the multifocal calcified region. The last one, really difficult balloon passage. This is suggested by the Dr. Ando from Japan. By the bidirectional approach, pull-through technique from the externalization of the retroid wire, then just deliver the entered balloon by forceful passage, then you can start the ballooning. And this retroid approach is also one last option for the pull-through technique, bidirectional ballooning. And this is a good for last technique, bed form technique, so-called. So in summary, once you cross any wire, and then the calcified problem is the device passage failure. So you have to make the space. The focal passage failure, this external Pearson technique is one of good, easy, cheap technique to solve the problem. However, some diffuse calcified region, we may need the excellent balloon and the making space strategy using the multiple CT wiring or the rotablation and some special device, including the plaque modification and calcium modification devices and some specialized balloon technique. And with the combination on use of stepwise technique, one by one, or the combination of a suggested method, I think the most of the calcified focally or the diffuse calcification, we can overcome the SFA or the bit below the knee region. These are based on my experience. Thank you for your attention.
Thank you very much, Dr. Ra. That has been wonderful. I mean, if there's any question in the panel, Dr. Srinivas, Dr. Kadru, you're free to ask. I have a question. What is the role, I mean, your experience with the endovascular lithotripsy in highly calcified lesions of the lower limb in your center?
Actually, I heard the lithotripsy can be useful, one of good option, but not available in Korea. Some company are preparing to deliver it, but actually personally no experience. I just heard about it and saw the presentation, but available in India?
Yeah, it's available in India. We did the first case about 2 years back in India. But the cost is so high, you know. The cost of a lithoplasty balloon itself is 2.5 times the cost of the procedure. So the technical use is very little, practical use. The other thing is they come only in a size which is 7. So, and they're good for SFAs and below knee, but iliacs, especially after external iliac, they lose their importance because the maximum available diameter is only 7 millimeter.
Okay. So practically, I think in India also, but in Korea, many critically ischemia patients, they are not so economically good condition. Chronically diseased, and many are CRF diabetic, long-standing disease, and they consumed a lot of money for the chronic disease, and economically very heavy burden, and actually difficult to support financially for the medical cost for the procedure. So our usual question is to follow the cheaper technique and the less expensive and the shorter procedure time, and then going to complex and the expensive one. So that is the usual question. So that's why I'm pursuing this kind of multiple CT wiring and the simple stiffer and the hard balloon, high pressure, and the plug modification, and the piercing, and some simple strategy first, and then going to be special. The special device actually much expensive than the simple way. That's why.
I absolutely agree. In India, we have the same set of problems. You have high incidence of diabetes, CRF, smoking, Burgess disease, and we are left with no options. And the patients, normally the insurance in India is still very poor, so they pay out of their pocket. So we also have the same techniques to go around, and rather than going on for very fancy dedicated devices. Okay, thank you so much, and I would request you to be on the expert panel.